Every 40 seconds, somewhere on this planet, someone has a stroke. By the time you finish this sentence, another brain has been hit. Every year, stroke kills almost 6 million people worldwide, ranks as the second leading cause of death, and is the number one reason people end up with permanent disability. The part nobody tells you clearly enough, in a huge number of cases, the brain gives you very specific warnings hours or days before the big stroke. You just have to know what they look like, if you want health information explained. In plain language, with no drama and no sugarcoating, subscribe and tap like. The goal for Dr. Waterling is 200,000 subscribers, and you can actually move that number. I share extra checklists and practical health posts on my Telegram. The QR code is on screen if you want to grab those. Stroke is not just, you were fine, you fell, you woke up in the hospital. In most cases, stroke is the predictable endpoint of blood vessels that have been degrading for years. If something is predictable, it is at least partly preventable. That is the whole point of this video. When people say stroke, they are actually talking about two very different events in the brain. One is a hemorrhagic stroke. A blood vessel in the brain bursts. Blood pours into or around the brain, forms a clot that compresses brain tissue, and a lot of those patients die. The other is an ischemic stroke. A vessel does not tear, but gets blocked. Blood flow stops to part of the brain, and brain cells in that zone start dying in roughly 4 to 6 minutes. Ischemic strokes make up around 85% of all strokes. So, that is what I'm going to focus on today. To understand why every minute matters, you need a feel for how demanding your brain actually is. Your brain weighs roughly 1.4 kg, about 2% of your body weight, but it uses around 20% of the oxygen you breathe in and about 25% of all the glucose circulating in your blood. It is a control center that never turns off, and it needs a constant fuel line. Cut that fuel for even a few minutes, and cells start dying in ways you cannot reverse. That is why doctors say stroke is a race against time. It is literally a race to save brain tissue before it is gone for good. Most people miss what I'm about to say. For a brain artery to suddenly block, the groundwork usually took years. The walls of the vessel have been damaged, collateral and clots have been building up, the opening has been getting tighter. This is not an explosion out of nowhere. It is the last step of a long process. Along that road, your body usually sends out warning signals. The problem is, nobody ever taught you how to read them. In medicine, those early warning shots are called a transient ischemic attack, or TIA for short. Transient just means temporary. It comes and it goes. Picture a carotid artery, the main neck artery that carries blood from your heart up to your brain. Over years, a fatty plaque forms on the inner wall right where the artery branches. The opening slowly narrows. Then at some point, the already tight vessel goes into a brief spasm. Blood flow stops for a few seconds or a few minutes, and the brain area fed by that artery basically blacks out for that short time. You see or feel a stroke symptom, then the spasm relaxes, blood flow returns, and the symptom fades, and you think you are fine again. What research actually shows is that a transient ischemic attack very often comes right before a major ischemic stroke, typically within the next 72 hours. Those 3 days are your window where the disaster can still be prevented. Most people do not use that window because the warning episode was short, strange, and then went away, so they talk themselves out of taking it seriously. These warning episodes usually last from about half a minute to maybe 10 minutes. That is exactly why they slip through the cracks. You can be in your kitchen, in the shower, getting out of a car, and by the time you stop and think, the symptom has already passed. But each of those episodes is your brain sending a final, very clear message. I am about to be in serious trouble. I want to walk you through the 5 big red flags and explain not just what they look like, but what is actually happening inside your body each time. The first warning sign is temporary blindness in one eye. You get up, walk toward the kitchen, and suddenly one eye goes dark or foggy, like someone pulled down a black curtain over that eye or smeared the lens with gray mud. You blink a few times, maybe rub the eye, and within seconds or a minute at most, your vision comes back. So, you blame it on standing up too fast or too much screen time. In reality, that curtain is almost always a tiny clot or a small fragment of plaque that broke off from the wall of your carotid artery, traveled up, and briefly plug the artery that feeds the eye. The artery to your eye is not some random, isolated tube. It is a direct branch of the inner carotid artery that feeds your brain. When the clot or plaque fragment wedges into that tiny eye artery, blood cannot get through. So, the retina, the light-sensing tissue, loses its blood supply for a moment, and you see darkness or a smear instead of a clear image. When the clot drifts away and blood flow restarts, the vision comes back, and you feel lucky. You were lucky because that exact same clot could have gone 2 mm to the side into a brain artery, and then instead of a 1-minute blackout in one eye, you are looking at permanent loss of speech, paralysis of an arm and leg, or death. Doctors have a classic Latin name for that one-eye blackout, amaurosis fugax, which literally means fleeting blindness. Neurologists treat that phrase like a fire alarm. If a patient describes an episode like that, they get urgent evaluation because the risk of a real stroke in the next hours is high. Hospital records show a pattern where a person ignores 2 or 3 of these eye episodes, and the very next one is the big one in the brain. The second warning sign is sudden numbness or tingling on one side of your body. The medical word is paresthesia, but you can think of it as your skin acting drunk. It can be the whole arm, just the hand, half the face, or even one full side of the body. It feels like pins and needles, like cotton, or like that body part has turned into rubber. The key detail is that it comes out of nowhere while you are just sitting, walking, or talking, lasts a few minutes, then goes away on its own. You have probably slept on your arm at some point where nerve compression causes numbness that clears up when you move. That is different. There, your brain and spinal cord are fine. You squeeze the nerve, and as soon as blood flow and position normalize, sensation returns in a minute or two. With a TIA, the problem is not in the arm. It is in the brain area that maps sensation from that arm, and the episode has nothing to do with posture. One more thing worth knowing, stroke symptoms are usually one-sided because each brain hemisphere controls and feels the opposite side of your body. When both hands go numb evenly, that more often points to neck spine issues. But a sudden one-sided numbness that resolves after a few minutes is a strong reason to get checked for TIA and stroke risk. The third warning sign is a sudden loss of coordination, what people describe as a drunk walk without any alcohol. You are on a flat, familiar surface, and out of nowhere, your foot lands in the wrong place. Your leg feels weak or rubbery, or you stagger into the wall for a second. Or you get hit by a sudden, strong spinning sensation that makes you grab a chair or the door frame. Even though you were not spinning, you did not jerk your head, and you did not just stand up from bed. The part of your brain that keeps you balanced and coordinates smooth movement is called the cerebellum. It sits low in the back of your skull like a small extra brain. It constantly calculates where your body is in space and how hard each muscle should fire, so you walk straight instead of zigzagging. The cerebellum gets its blood supply from arteries that run up through the bones of your neck into the back of your head, what doctors call the vertebrovascular system. If blood flow in those arteries drops sharply, even for a few seconds, the cerebellum essentially glitches. That is when you suddenly veer sideways, misstep, or feel violent dizziness for no obvious reason. In clinical practice, there is a pattern where people write off these episodes as bad shoes, I was tired, or must be my blood pressure, and only find out later that those were cerebellar transient attacks. Benign dizziness usually has a clear trigger, rolling over in bed, turning the head quickly, a known inner ear condition. But spontaneous, intense dizziness plus. Any trouble walking straight should be treated as a possible TIA until a doctor rules out a vascular cause. The fourth warning sign is in your speech. Before we go further, I want to be clear about something. If you occasionally cannot remember your neighbor's name, or you temporarily forget the word for toothbrush, that is not a stroke sign. That is a normal tip-of-the-tongue moment that happens more when you are tired or stressed. What worries neurologists is something quite different. When your speech suddenly breaks down so badly that even you feel something is seriously wrong. There are two main speech areas in most people's brains, both usually in the left hemisphere. One area, often called Broca's area, helps you form words and send clear instructions to the muscles of your tongue, lips, and jaw. When that region loses blood flow, you may understand everything people say. You know what you want to answer, but you cannot get the words out. They come out slurred, chopped, or stuck. The other. area, often called Wernicke's area, helps you understand speech and organize your own sentences so they make sense. When that zone is in trouble, a person may speak fluently, but say complete nonsense, like word salad, and may not understand simple phrases directed at them. If any of those speech problems show up suddenly and then fade after a few minutes, that is classic for a TIA, not "I was just tired." You cannot ignore broken speech just because it's self-corrected. That is like your home alarm going off, stopping by itself, and you deciding it was probably nothing. The fifth warning sign is less obvious and surprises most people. It is a combination of certain skin changes plus new and usually strong headaches. The skin condition is vitiligo, patches of pale or completely white skin where pigment-producing cells have stopped working. Vitiligo is an autoimmune process, meaning the immune system starts attacking your own pigment cells as if they were foreign. When your immune system goes off target like that, it often does not stop at one organ. In many people, that same autoimmune process can quietly inflame the inner lining of blood vessels as well. That inner lining is called the endothelium, a microscopically thin layer of cells that coats the inside of every artery like a super smooth non-stick surface. When the endothelium is healthy, blood components glide by and nothing really sticks. When it is damaged by inflammation, it becomes rough and scarred and things start to cling. Cholesterol, platelets, various inflammatory proteins forming the seeds of plaques and clots over time. Vitiligo alone does not doom you to a stroke, but if on top of that you develop frequent and usually intense headaches that do not fit your usual pattern, that combination deserves a proper vascular workup rather than a wait-and-see approach. Headaches in general are tricky because a lot of people blame bad vessels when the real problem is elsewhere. A very common cause of daily or frequent head pain is wear and tear in the small joints between the second and third neck vertebrae, basically arthritis in the neck. That joint degeneration can irritate nearby nerves and send pain up into the head, which has nothing to do with a brain artery being blocked. On top of that, many people carry an undiagnosed neck disc herniation. And if you never address it, in severe cases, it can threaten the nerve supply to your arms or legs. Headaches should not just be numbed with pills long term. They need to be decoded with a doctor, especially when they change character or pair up with other warning signs like the ones we just covered. Now I want to talk about what really wrecks your blood vessels from the inside, because this is where one of the biggest myths lies. The myth, my cholesterol is normal, so I am safe from stroke. Stroke risk is not just about what is floating in your blood. It is very much about the condition of that endothelial lining on the inside of your vessels. Think back to that non-stick pan idea. While the coating is intact, food does not cling. Once you scratch and damage it, everything starts sticking and burning. The first major enemy of the endothelium is chronically high blood sugar. Glucose is your cell's fuel, but to get from the blood into endothelial cells, it needs insulin, the hormone that basically opens the door into the cell. When your body does not make enough insulin or your cells become resistant to it, you can have plenty of sugar in your blood while the vessel lining cells are still starving. Starving cells get damaged, lose their shape, and can even peel off the inner surface, leaving behind rough, scar-like patches. Those scarred zones cannot contract properly when your blood pressure changes. Doctors call that a loss of vasomotor reserve, meaning the vessel has lost its flexibility. And those rough spots are perfect landing pads for, quote, bad cholesterol, specifically low-density lipoproteins, plus platelets and other blood components. Over time, these deposits grow into the plaques that narrow and stiffen your arteries. This process starts years before anyone officially tells you that you have diabetes. Even mild prediabetes, where your glucose is only slightly above normal, is enough to injure the endothelium quietly for a long time. The second big vascular enemy is smoking. Cigarette smoke contains thousands of chemicals, and dozens of them are known cancer-causing substances. But for stroke, the concern is specifically their effect on the endothelium and the blood itself. With every cigarette, toxic compounds hit the inner surface of your vessels and cause direct chemical damage and inflammation. At the same time, nicotine and carbon monoxide make your blood thicker and stickier, increasing how easily platelets clump and how readily clots form. When you put a damaged, inflamed vessel wall together with thick, sticky blood, you create ideal conditions for a clot to plug a brain artery. That is why smokers have roughly 2 to 4 times the risk of an ischemic stroke compared to non-smokers with similar cholesterol and blood pressure numbers. Blood pressure adds another layer of confusion because the myth here runs in the opposite direction. Many people have heard that stroke comes from high blood pressure, so they are terrified of a high reading and relieved when the pressure is low or normal. Chronically high blood pressure, hypertension, absolutely is one of the strongest risk factors for stroke because over years it physically stresses and weakens vessel walls and speeds up plaque formation. It is also the main driver behind hemorrhagic strokes, where a vessel literally bursts. There is a twist though. An ischemic stroke often happens, not at the peak of blood pressure, but at a relative low point. Picture a brain artery that is already narrowed by more than half because of a plaque. It is like a water pipe that someone has squeezed in the middle. As long as the pressure in the system is high enough, some water still squeezes through that tight segment. But if the overall pressure falls, the flow through that narrowed point can drop to almost zero, especially if a small clot gets stuck there and the system does not have enough push to move it along. At night, while you sleep, blood pressure naturally falls by roughly 15 to 20%. This is a normal physiological dip, not a disease. If you already have a plaque-narrowed artery, that nighttime drop can be enough a partial blockage into a full stop, especially if a clot has formed on that plaque while you were lying quietly. That is one reason some people go to bed feeling fine and wake up with stroke symptoms, or someone finds them that way in the morning. Age plays a role, but not in the simple stroke is only for old people way you hear at. Family dinners. Yes, stroke risk rises significantly after about 50 and roughly doubles with each additional decade. In older adults, the dominant causes tend to be atherosclerosis, plaque buildup, along with long-standing high blood pressure and heart rhythm problems. But about 10 to 15% of strokes happen in people younger than 45. In those younger patients, the records show different drivers: congenital vessel abnormalities, bulging weak spots in vessel walls called aneurysms that can rupture, clotting disorders, autoimmune diseases, and trauma to the head or neck. Another thing worth understanding, the speed of vascular damage from the same risk factors changes with age. After about 40, plaque buildup and endothelial injury from things like smoking, high sugar, or high pressure tends to run about twice as fast as it did in your 30s. That is one reason doctors get more direct about risk factor control as patients move through their 40s and 50s. So let me ask you something. How old are you right now? Your age changes how quickly you are. Vessels respond to the same risk factors and shifts, which causes of stroke are more likely in your specific situation. That really matters for what you and your doctor should be paying attention to. Now, the most practical part. What do you do if you have already had even one of those 5 warning episodes, even if it felt small and vanished in under 10 minutes? You have roughly 72 hours where a lot can still be done to prevent a full-blown stroke. The goal is not to panic, but also not to waste that window. Stroke specialists often point out how important it is not to be completely alone after a suspected transient attack. This is worth planning ahead with your family and your doctor, especially if you live by yourself. If another more serious episode happens and you suddenly cannot speak or move, you need another person who can see it, call emergency services, and get to you quickly. Many people find it helpful to tell a close person what happened and make sure someone can reach them easily over the next couple of days. That is a reasonable thing to bring up with your healthcare provider. Stroke guidelines also advise against driving yourself after a possible TIA. Losing vision or arm control for even a few seconds at highway speed is life-threatening for you and everyone around you. It is worth talking ahead of time with your doctor about what transportation plan makes sense in your situation if something like this ever happens, so you are not tempted to just drive yourself in. Checking blood pressure is usually among the first steps in almost any acute situation. If you or someone near you can measure it, and the top number, the systolic pressure, is around 180 or higher, and the bottom number, the diastolic, is around 110 or higher, that fits the picture of a hypertensive crisis, not just elevated blood pressure. A crisis like that is itself a strong warning sign for stroke, and calling emergency services right away is what standard guidelines often recommend. Ask your doctor explicitly about this threshold so you know in advance when to treat it as an emergency. One rule from stroke medicine is strict. Never start blood-thinning drugs like aspirin, anticoagulants, or similar medications on your own based on a friend's advice or something you read online. There are two main types of stroke: ischemic, where a vessel is blocked, and hemorrhagic, where a vessel is bleeding. Thinning the blood can help in certain ischemic situations, but in a hemorrhagic stroke, it can make the bleeding faster and larger, which can kill a person more quickly. The only way to tell the difference reliably is with brain imaging, usually a CT scan in a hospital. No doctor can look at someone and be 100% certain which type is happening without a scan. So, instead of self-treating, the right move is to get evaluated and let a medical team decide. You can absolutely ask your doctor in advance how they would want you to act if you ever suspect a stroke. While waiting for help or on the way to care, body position matters. Lying down is generally better than sitting bolt upright because it helps blood flow to the brain. Many clinicians suggest a comfortable flat position with the legs slightly raised above chest level to support circulation and ease the heart's work. The head should be neutral, not bent sharply forward and not thrown back, so that neck vessels are not kinked. It is also wise to avoid smoking, alcohol, or exposure to hot baths or very hot showers in that moment, since sudden vessel dilation in an already unstable circulation can make things worse. Double-check this with your own doctor. Having a written list of all the medications you take regularly, kept somewhere easy to find, is a small step that can save precious minutes for emergency teams. Something many people get wrong. If 72 hours pass and no new episode happens, that does not mean you are in the clear. It means you were given a second chance and you still need to use it. There are 3 evaluations that are very reasonable to ask about at your next medical visit if you have had any of these warning signs. Each one looks at a different piece of the stroke puzzle. The first is a specialized ultrasound of your neck arteries called carotid duplex ultrasound. Unlike a basic ultrasound that just shows structure, duplex imaging shows both the anatomy of the artery and how blood is flowing through it, including whether the flow speeds up and becomes turbulent at a narrowed segment. If the carotid artery is narrowed by more than roughly 70% by plaque, doctors call that a hemodynamically significant stenosis, meaning the narrowing is severe enough to seriously impair blood flow. At that point, the question is less will a stroke ever happen, and more, when will it happen if nothing changes? That is why surgeons may suggest a procedure called carotid endarterectomy, where they open the artery and remove the plaque. It sounds dramatic, but in modern practice, it is a routine surgery that saves tens of thousands of people from stroke every year. If you have risk factors or symptoms, asking your doctor about a carotid ultrasound is a reasonable conversation to have. The second test is a blood test called glycated hemoglobin or HbA1c. This is ordinary hemoglobin, the oxygen-carrying protein in your red blood cells that has sugar molecules stuck to it. The higher your blood sugar has been over the past months, the more of your hemoglobin becomes sugar-coated. That is why this test reflects your average blood sugar over about 3 months rather than just a single morning. Snapshot like a fasting glucose test. You cannot game a good HbA1c with one perfect fasting result the day before the blood draw. It is especially good at catching that gray zone called prediabetes, where sugar has been high enough long enough to damage vessels, but nobody has labeled it diabetes yet. The cutoffs are clear. Glycated hemoglobin under about 5.7% is normal. 5.7 to 6.4% is prediabetes, and 6.5% or higher typically fits diabetes. If you have never had this test or it has been years, that is an easy thing to bring up with your doctor, especially if you have any stroke risk factors. The third investigation is Holter monitoring of the ECG. In plain terms, a 24-hour heart rhythm recording. Instead of a 10 or 20-second electrocardiogram in the clinic, you wear a small device for a full day while you go about your normal routine. The reason is straightforward. Some dangerous heart rhythm problems come and go. They might show up once or twice a day for a few seconds and be completely missed by a short snapshot ECG. The biggest rhythm culprit for stroke is atrial fibrillation or AFib. In AFib, the upper chambers of the heart, the atria, stop beating in a steady, organized way and instead quiver chaotically, sometimes at rates of 300 to 400 contractions per minute. When that happens, blood does not empty smoothly from the atria. It churns and swirls instead of flowing. And in that swirling blood, clots form very easily. Those clots can shoot out of the heart, travel up to the brain, and lodge in an artery. That is called a cardioembolic stroke, and it tends to be severe. Many people with atrial fibrillation do not feel dramatic symptoms. At most, they notice occasional skipped beats, brief flutters, or they blame it on stress or caffeine. Holter monitoring is what catches these hidden episodes. If a fib is found, there are well-studied medications called anticoagulants, blood thinners, that when prescribed and monitored correctly, can cut the stroke risk in this condition by roughly 60 to 70%. That is not an inevitable outcome. That is a risk you and your cardiologist can actively work on. Stepping back, stroke is not a lightning bolt from a clear sky. It is a predictable event that usually comes after years of silent vessel damage, and it often announces itself in advance. You now know the big ones: brief blindness in one eye, sudden one-sided numbness or tingling, abrupt loss of coordination or a drunk walk, sudden serious speech breakdown, and vitiligo combined with new, unusual headaches. Any of these showing up for the first time, even if they vanish in a minute, is a reason to talk to a doctor urgently and ask about those three evaluations: carotid duplex ultrasound, glycated hemoglobin, and Holter ECG monitoring. On the prevention side, there are things research ties to lower stroke risk. Keeping blood sugar in a healthy range and catching prediabetes early protects the endothelium and slows plaque growth. Managing blood pressure with your doctor's help, not just pushing it down at all costs, but avoiding both extremes, reduces strain on your vessels and lowers both hemorrhagic and ischemic risk. Stopping smoking, with support if you need it, removes a constant chemical assault on your arteries and cuts your ischemic stroke risk by roughly a factor of 2 to 4 over time. And the most important thing to internalize: do not wait for brief brain symptoms to go away by themselves. In the stroke world, you have about 72 hours to act. Here is what to do after this video. If you recognize any of the 5 warning signs from your own life, even from months ago, write them down in plain language and bring that list to a doctor. Do not rely on memory. Ask directly whether you should be evaluated for transient ischemic attacks and whether carotid ultrasound, glycated hemoglobin, or Holter monitoring makes sense in your case. If you have risk factors like high sugar, high pressure, smoking, or autoimmune conditions, use what you learned here to have a more specific conversation with your doctor about stroke prevention rather than walking away with everything looks fine and no actual numbers. Everything we covered today is for your understanding and education. Your situation is specific to you, and using this as a starting point for a real conversation with your doctor will always be more useful than trying to manage things on your own. If this made a complicated topic easier to follow, subscribe and hit like. That is how Dr. Waterling gets closer to that goal of 200,000 subscribers. And if you want something practical to keep on your phone, scan the QR code on screen to join my Telegram, where I post short checklists and step-by-step health tips.